metabolic acidosis, metabolic alkalosis, and their causes. You should be able to identify whether the pH is indicating acidosis or alkalosis, and what is their compensatory mechanisms. You should also able to define the anion gap and its types and significance. Identify if there is any compensation for acid base imbalance. The case of today's lecture is a 25-year-old diabetic patient was brought in the emergency room in a comatose state. History revealed diarrhea and vomiting since 2 days, and her breath has fruity odor. She takes insulin therapy for her blood glucose control, and her ABGs showed a pH of 7.19, a PaCO2 of 32, and PaO2 of 110, while bicarbonate level is 9. Her electrolytes show a sodium of 131 milliequivalents per liter, potassium of 5.3 milliequivalents per liter, chloride of 96 milliequivalents per liter, bicarbonate 10 milliequivalents per liter, and a glucose level of 655 milligram per dl. So, from these values, you can easily identify the acid base disturbance of this patient by the end of the lecture. The normal body homeostasis of the pH should be tightly controlled at the level of 7.4, while the blood pH is 7.35 to 7.45. And as we have discussed in the last lecture, that a person cannot survive on a pH of less than 6.8 or a pH of more than 8, person is unable to survive, and death usually occurs. Whenever the pH falls below 7.35, we label it as acidosis or acidemia, and whenever the pH is increased more than 7.45, then we label the person as alkalemia. So, for the proper functioning of the body, we have to have a normal pH at all the time. If there is slight point disturbance in the pH occurs, then the body's homeostasis gets drastically disturbed. These are the normal values of uh, ABGs. Normal pH 7.35 to 7.45. This reflects the hydrogen ion concentration in the body. If the pH is less than 7.35, we call it as acidosis. If the pH rises above 7.45, we label as alkalosis. Normal PaCO2 is 35 to 45 millimeters of mercury, and the partial pressure of this carbon dioxide arterial blood, if less than 35, we call it as hypocapnia. If it's more than 45, we call it as hypercapnia. The PaO2 is 80 to 100 millimeters of mercury, and if it's less than 80 millimeters of mercury, then hypoxemia can occur. This PaO2 can also be measured by a instrument which is put in the thumb, and that will give the saturation of oxygen in the body fluids. Normal saturation should be 95 to 100 millimeters of mercury, and below 95 is we normally we take up to 90 saturation if there is no clinical sign and symptoms present in a person. So the serum bicarb level normally is 22 to 26 milliequivalents per liter. So the body is continuously producing lots of acids in the body, either in the form of volatile acids, which is the carbon dioxide, continuous production of carbon dioxide through the oxidative metabolism of carbohydrates, fats, and proteins. And this carbon dioxide can be excreted out through the lungs as carbon dioxide gas. The other form of acid production is fixed acids, which is producing at a level of 1 milliequivalent per kg per day, and these acids are not cannot be removed through the lungs in the form of carbon dioxide. They have to be eliminated by the kidneys because they remain in the body once they are produced, so they need to be excreted out from the kidneys. And these fixed acids are the sulfuric acid, phosphoric acid, organic acid, and these are important fixed acids in the body, and they are continuously generated during the catabolism of amino acids like oxidation of sulfhydryl groups of cysteine or methionine. They are generated in phospholipid hydrolysis uh, metabolism, and they are generated in nucleic acid formation. So in order to maintain a uh, normal acid base balance, not only the body is producing acids and continuously producing acids in the form of volatile acids and fixed acids, but certain foods which we are consuming are also producing these hydrogen ions uh, according to the food we are taking in. Some food have alkaline in nature, and they are alkaline forming foods like fruits, vegetables, peas, beans, lentils, spices, herbs, seeds, and nuts. While consumption of acid forming foods like meat, fish, poultry, egg, and grains and legumes. So, if a person is consuming more amount of acid forming foods like meat, fish, egg, and legumes, then definitely this is also adding up the acid production in our body. Similarly, if a person is taking purely vegetables or a vegetarian person, then the person is producing alkalinity through the foods as well as production of acids through the metabolism which is going on inside our body. So, to maintain the normal health, the diet should consist of 60% of alkaline forming foods and 40% of acid forming foods. To restore the health, the diet should consist of 80% alkaline forming foods and 20% acid forming foods. So, what is acidosis? Acidosis is excessive production of acids in the blood. It could either be due to an overabundance of the acid in the blood, or it could be due to loss of bicarbonate from the blood, or it could be due to a buildup of carbon dioxide in the blood. All these three reasons can lead to acidosis. Blood acidity also increases in persons who ingest or consume acid forming foods, or when the lungs are unable to expel enough carbon dioxide. So, acidosis is of two types, and alkalosis is also of two types. Acidosis could be metabolic or could be respiratory. In metabolic acidosis, the primary problem is with the bicarbonate. There is decreased bicarbonate levels. While in respiratory acidosis, the primary problem is with the carbonic acid or carbon dioxide, increased formation of carbonic acid. In case of alkalosis, In metabolic alkalosis, there is increased production of bicarbonate ions, while in respiratory alkalosis, there is decreased formation of carbonic acid. So, in acidosis, there is decreased pH and decreased bicarbonate, thus decreasing the acid base ratio. And this can lead to metabolic acidosis, and this is regulated by the kidneys because the kidneys will regulate this bicarbonate chunk. In metabolic acidosis, the primary uh, defect is in the bicarbonate, and there is alkali deficit or bicarbonate deficit which occurs in metabolic acidosis. We can remember this metabolic disturbance by the mnemonic ROME. R represents respiratory and O represents opposite. M represents metabolic and E represents equal. You can see here in respiratory, whether it's acidosis or alkalosis, these pH and carbon dioxide will go in opposite direction. If one is increasing, the other is decreasing, and this occurs in alkalosis. If pH is decreasing and PCO2 is increasing, then respiratory acidosis, and if pH is increasing and PCO2 is decreasing, then we call it as respiratory alkalosis. While in metabolic acidosis, both the things, uh, pH and bicarb, go in the same direction. In case of acidosis, if pH drops, then bicarbonate also decreases and there is acidosis. In case of metabolic alkalosis, if pH is increasing, then bicarbonate will also increase. So you can remember this disturbance by the mnemonic ROME. So metabolic acidosis occurs due to decreased ability of the kidneys to excrete the acids or conserve the base. In this case, the pH drops below 7.35 as well as bicarbonate drops below its normal level. The causes could be diabetes mellitus, especially diabetic ketoacidosis, renal failure, lactic acidosis, severe diarrhea, and renal tubular acidosis. The symptoms that can patient present with is hyperkalemia, decreased blood pressure, lethargy, headache, warm flushed skin, nausea, vomiting, diarrhea, loss of consciousness or coma, or sometimes death. These are the signs and symptoms by which the patient can present in the emergency room. In case of acidosis, there could be headache, sleepiness, confusion, loss of consciousness or coma. There could be seizure or weakness. There could be diarrhea, nausea, vomiting. Sometimes arrhythmia and increased heart rate can be a presentation. In case of respiratory acidosis, the patient will present with shortness of breath and cough. So the causes of acidosis uh, uh, can be labeled when the pH falls below 7.45, 7.4. In case of metabolic acidosis, the pH drops and the bicarbonate drops. The common causes are diabetic ketoacidosis, shock, sepsis, severe diarrhea, renal failure, or salicylate overdose or intoxication. These are the common reasons due to which the person person can go in metabolic acidosis. In case of respiratory acidosis, in this case, the pH if the pH drops, then PCO2 will rise. The common causes are drug overdose, pulmonary edema, chest trauma or neuromuscular disease, chronic obstructive pulmonary disease or COPDs, or there could be airway obstruction. And in this case, the person will hypoventilate, while in this case, in metabolic acidosis, the person will hyperventilate. So, in metabolic acidosis, the bicarbonate deficit occurs whenever the bicarbonate level falls below 22 milliequivalents per liter. And the most common causes could be either the loss of bicarbonate through diarrhea or renal dysfunction, or there is accumulation of acids like lactic acid or ketone body accumulation, which may be seen in starvation and high grade fever, while failure of the kidneys to excrete hydrogen ions. These are the common three reasons due to which metabolic acidosis can occur. So, increased production of hydrogen ion concentration is seen in diabetic ketoacidosis, in starvation, lactic acidosis, and salicylate intoxication. Impaired excretion of hydrogen ion can be seen when there is renal failure or renal tubular acidosis type 2. Loss of bicarbonate from the GI tract or in the urine can be seen in severe diarrhea, in renal tubular acidosis or type 1, and ureterosigmoidostomy. So, in whenever there is loss of bicarbonate, either due to these reasons, it is replaced by the chloride, and this results in hyperchloremic acidosis. This is the acid base disturbance seen in the case of acidosis. What happens here is increased production of hydrogen ions continuously adding from the catabolism, and this will can either combine with carbonic acid and form water and carbon dioxide and can be exhaled out, or this bicarbonate can enter, this hydrogen ion can enter the kidneys and secreted and kidneys will secrete hydrogen ions. This bicarbonate can enter the bicarbonate reserve system and will combine with sodium and form sodium bicarbonate, and thus continuously increasing or generating bicarbonate levels. So, in this case, this is the normal balance of our body with the ratio of 20 is to 1 bicarb is to carbonic acid at a pH of 7.4. When the pH starts disturbing and it starts dropping down or to 7.1, this bicarbonate decreases, and because of excess presence of ketones, chlorides, or organic acids, the body starts its compensatory mechanism by hyperactive breathing to blow off the carbon dioxide. So the patient starts hyperventilating, and the kidney starts conserving bicarbonate and eliminate hydrogen ion in the acidic urine, and thus kidneys start conserving bicarb and excreting out the hydrogen ion, so the acid can be excreted out in the urine, and here the acid can be excreted out exhaled out from the lungs. So this disturbance starts to come back to its normal balance levels, along with the addition of a lactating containing solution, or we start the therapy so that that can normalize the ratio and brings back the ratio of 20 is to 1. In metabolic acidosis, it's not just treating the fluid environment or fluid balance, but it's also treating the cause of the disease and regulating the fluid balance to a homeostasis level. by therapy as well as by medicines which can treat the cause of the disease. So, in metabolic acidosis, the pH decreases. This means that there is hydrogen ion concentration increasing, and the primary disturbance is decrease in bicarbonate ion, and the secondary response is decrease in PCO2. While in metabolic alkalosis, there is increased pH, means that the hydrogen ion concentration is decreasing, while bicarbonate ion concentration is increasing. And the secondary response is increasing PCO2. So, the compensatory mechanism for metabolic acidosis can be regulated by these buffering mechanisms. First is the bicarbonate buffering mechanism, then intracellular buffering system, respiratory compensation, and renal compensation. In bicarbonate buffering system, the carbon dioxide combines with water to form carbonic acid, which in turn rapidly dissociates into hydrogen ion and bicarb ions. And this reaction is catalyzed by the enzyme carbonic anhydrase. While in intracellular buffering, by the absorption of hydrogen atoms by various molecules like proteins, phosphates, and carbonates in the bone, can also cause intracellular buffering. Respiratory compensation is the mechanism by which plasma pH can be altered by varying the rate of respiration. It is faster than renal compensation but has less ability to restore the values back to their normal levels. In case of metabolic acidosis, the chemoreceptors sense a deranged acid base system and there is increased breathing. So, the compensatory mechanism of metabolic acidosis is hyperventilation. Then second line of defense is taken over by the renal compensation in metabolic acidosis. In this, the kidneys produces and excretes ammonium ions and monophosphate, thus generating the bicarbonate ion in the process while clearing the acids. Then we will see how these kidneys regulate the metabolic acidosis and alkalosis. They achieve this by four mechanisms. They excrete causes excretion of hydrogen ions, they causes reabsorption of bicarbonate ions, they causes excretion of titratable acids and excretion of ammonium ions. Only kidneys can remove the fixed acids which are generated in the cellular metabolism by two methods. If the case is of acidosis, then the kidneys will retain bicarbonate ions and eliminate hydrogen ions. If the case is of alkalosis, then the kidneys will eliminate bicarbonate ions and retain the hydrogen ions. To maintain the normal pH, the kidneys must perform two physiological functions. Either they reabsorb all the filtered bicarb through the proximal convoluted tubule, or they excrete the daily hydrogen ion load through the collecting duct. So, renal regulation. In renal regulation, there is continuous generation of new bicarbonate ion, which is increasing the alkali, which is forming the alkali reserve. While excretion of buffered hydrogen ions, uh, which is seen in alpha intercalated cells of the renal tubules, that synthesizes new bicarbonate ion while excreting more hydrogen ions. This is the reabsorption of bicarbonate ion. There are seven steps which can be seen here. This is the filtrate in the tubular lumen. These are the tight junctions. This is the proximal convoluted tubule cell, and these are the peritubular capillaries. First, carbon dioxide combines with water within the tubular cell, forming the carbonic acid. Then carbonic acid is quickly split up into hydrogen ion and bicarbonate ions. The hydrogen ion is secreted into the filtrate. Once it is secreted into the filtrate, it again combines with bicarbonate ion and form carbonic acid and enters the peritubular capillary blood either via symport with sodium or via antiport with chloride. Then the secreted hydrogen ion combines with bicarbonate ion in the filtrate, forming the carbonic acid. The bicarbonate disappears from the filtrate at the same rate that bicarbonate formed within the tubular cell and enters the peritubular capillary blood. This bicarbonate formed in the filtrate then dissociates into carbon dioxide and water, and this carbon dioxide then diffuses into the tubular cells where it triggers further hydrogen ion secretion. This is the synthesis of new bicarbonate and excretion of the buffered hydrogen ions. The sodium hydrogen antipode secretes hydrogen ions. This hydrogen ion in the filtrate combines with bicarbonate to form carbon dioxide and water. This carbon dioxide then diffuses into the cell and combines with water to form hydrogen ions and bicarbonate ions. This bicarbonate is then reabsorbed. There is glutamine is metabolized to ammonium ions and bicarbonate ions, and these ammonium ions is secreted and excreted while the bicarbonate ion is conserved or reabsorbed, and thus new bicarbonate ions are generated, and thus increasing helps in formation of the alkali reserve in the body. Whenever there is acidosis, the potassium ion goes up in acidosis. You have to remember this. So, in case of diabetic ketoacidosis, the potassium levels were found to be increased. In case of lactic acidosis and different types of acidosis, the potassium level goes up. Why this occurs? This occurs because potassium is an intracellular cation. In acidosis, there is an increase in hydrogen ion concentration in the ECF, and this leads to exchange of hydrogen ion with the intracellular potassium ion. Net effect is an increase in ECF potassium, that is, hyperkalemia occurs. Compensation of metabolic acidosis. Whenever there is decrease in pH in metabolic acidosis, it stimulates the respiratory compensatory mechanism, thus producing hyperventilation and Kussmaul respiration. This leads to an increased elimination of carbon dioxide from the body, hence, the carbonic acid is removed in the form of carbon dioxide. Thus, respiratory compensation is only short lived, while renal compensation sets in within 3 to 4 days, and hydrogen ions are excreted in the form of ammonium ions. Increase in renal reabsorption. What are the result of compensation of metabolic acidosis? There will be an increase in renal reabsorption of bicarbonate ions and a rise in urinary acid and ammonia production. Anion gap. The total concentration of cations and anions, which is expressed as milliequivalent per liter, is equal in the body fluids. This is required to maintain the normal electrical neutrality in the body. The commonly measured electrolytes in the plasma are sodium, potassium, chloride, and bicarbonate ions. Sodium and potassium together accounts for 95% of cations, while chloride and bicarbonate accounts for 86% of the anions. Hence, there is always a difference between the measured cations and the anions, and this is due to the presence of protein, anions, sulfate, phosphate, and organic acids. Here you can see in extracellular fluid there should be sum of anions equal to sum of cations in order to maintain the electrical neutrality. So the measured cations are sodium and potassium, while the unmeasured cations are calcium and magnesium. The measured anions are chloride and bicarbonate, while the unmeasured anions are protein, phosphate, organic acids, and sulfates. Sodium and potassium together accounts for 95% of cations. Chloride and bicarbonate account for 86% of the anions, and thus these anions and cations maintains the electrical neutrality. So anion gap is defined as the difference between the total concentration of measured cations and that of the measured anions. The anion gap is in fact represents the unmeasured anions in the plasma, which can be calculated by this formula, that is sodium plus chloride is equal to sodium plus potassium is equal to chloride plus bicarb plus anion gap. Normal sodium is 136, potassium is 4, chloride is 100, and bicarb is 25. So the normal anion gap came out to be 15 milliequivalent per liter, and in a healthy individual it ranges from 8 to 18 milliequivalent per liter. This is the anion gap seen in metabolic acidosis. The increased production and accumulation of organic acid causes an elevation in anion gap. This is a typical case of metabolic acidosis associated with diabetic ketoacidosis. In this figure, this is the normal picture showing the normal values of all the anions and cations with a normal anion gap. Then once acidosis sets in, the bicarbonate is reduced, causing an increase in the anion gap. In hyperchloremic acidosis, there is no change in the anion gap, but as the compensation, the chloride ion starts increasing. So, this is due to the presence of protein anions, sulfate, phosphate, and organic acids. Normal anion gap is about 15 milliequivalents. Normal range is 8 to 18 milliequivalents per liter. Why we need to uh, calculate the anion gap? In clinical setting, this anion gap is a biochemical tool that helps us in assessing the acid-base problems, and basically it is used for the diagnosis of different causes of metabolic acidosis. So there are certain causes that leads to high anion gap acidosis, that are renal failure, diabetic ketoacidosis, and lactic acidosis. Certain conditions, certain causes leads to normal anion gap acidosis. These are diarrhea and hyperchloremic acidosis, while certain conditions can lead to low anion gap acidosis. This is multiple myeloma. In alkalosis, there is increase in pH, so the bicarb level also rises, and thus the ratio also increases, and this leads to metabolic alkalosis. Kidneys regulate this metabolic component, and in metabolic alkalosis, the primary defect is alkali excess or bicarbonate excess. So, alkalosis is basically excessive blood alkalinity that is caused by overabundance of bicarbonate in the blood, or loss of acid from the blood, or by low levels of carbon dioxide in the blood that results from rapid or deep breathing like metabolic respiratory alkalosis. In metabolic acidosis, which is due to the gain of base or loss of acid, the primary abnormality is an increase in bicarbonate. The common causes could be increase in the bicarbonate in the blood, either due to ingestion of excessive amount of bicarbonate in the form of antacids, or eating excess fruits, vegetables, or seen in vegetarian diet or fat diets. Loss of acid from vomiting or loss of potassium from diuretics. So in metabolic alkalosis, there is a rise in blood pH due to rise in bicarbonate levels, thus leading to metabolic alkalosis. In this, again, this is reflecting the normal uh, acid base environment of the body, with a ratio of acid and base with of 20 is to 1 ratio, bicarb to carbonic acid at a pH of 7.4. Now, once the alkalosis sets in and the pH starts rising, the bicarbonate also increases. Could be due to loss of chloride ions or excess of ingestion of sodium bicarbonate. When this occurs, the ratio gets disturbed and more bicarbonates are formed, and the ratio becomes 40 is to 1. Now we have to start, the body starts its compensation by breathing, holding the breathing and thus holding the carbon dioxide. The kidneys starts conserving hydrogen ions and starts eliminating bicarbonate ion, thus alkaline urine is passed. And once therapy starts by chloride containing solutions, then this ratio, which was disturbed, quite disturbed, returns back to its normal values. In alkalosis occurs when the pH increases more than 7.4. There are two types of alkalosis: metabolic alkalosis and respiratory alkalosis. In metabolic alkalosis, both the pH and bicarb will rise. The common causes could be losses of gastric juices, potassium wasting, diuretics, or overuse of antacids. These all can lead to metabolic alkalosis. In case of respiratory alkalosis, the pH rises, then PCO2 will fall. And this could be seen in conditions when a person starts hyperventilating due to anxiety, or a person is going on high altitudes, or when there is pregnancy or high grade fever, or in the initial stages of pulmonary embolism. Common signs and symptoms of metabolic alkalosis are restlessness followed by lethargy. There could be dysrhythmias or tachycardia. There could be compensatory hypoventilation or confusion, dizziness, irritability, nausea, vomiting, diarrhea. There could be tremor, muscle cramps, tingling of fingers and toes, and hypokalemia. So, in metabolic alkalosis, the acid is decreasing while the base is increasing. The pH increases, bicarbonate also increases. And the most common causes of metabolic alkalosis are severe vomiting, excessive GI suction, diuretics, and excessive consumption of sodium bicarbonate. So, whenever there is acidosis, the pH slides down, pH decreases. Whenever there is alkalosis, the K kicks up the pH and the pH increases. So, increased pH leads to alkalosis, decreased pH leads to acidosis. The compensation of metabolic alkalosis is the respiratory mechanism initiates the compensation by hypoventilation so that it retains the carbon dioxide and thus retains the acid. This is slowly taken over by the renal mechanism, which then excretes more bicarbons and retains the hydrogen ions. This is the response to alkalosis. The hydrogen ion needs to be conserved, and bicarbonate needs to be excreted out from the body, while hypoventilation, decreasing respiratory rate, and decreasing PCO2 will retain carbon dioxide and thus will help in formation of more acids, and thus returning back the acid base disturbance back to normal. ABGs are or arterial blood gas analysis can be learned by this uh, triangle. The normal level is 7.35 to 7.45. Okay. We call acidosis when the pH rises more than 7.35 to 7.45. Alkalosis when the pH rises above 7.45. So anything below 7.35 is uncompensated acidosis. Anything above 7.45 is uncompensated alkalosis. Okay. If less than 7.4 but not below 7.35, then compensated acidosis occurs. If it is above 7.4 but not above 7.45, then compensated alkalosis sets in. If the PCO2 is less than 35, respiratory alkalosis. If PCO2 rises above 45 millimeters of mercury, then respiratory acidosis sets in. So the ABGs is arterial blood gas is a sample of the arterial blood that reports about the pH or hydrogen ion concentration, about the PaCO2 or dissolved carbon dioxide level in the blood, about bicarbonate levels or metabolic effectiveness, or PaCO2 about the oxygen content of the blood, and oxygen saturation of the hemoglobin by pulse oximeter. Arterial blood gas is a lab that shows us the status of the patient's chemical balance. It is done by through the arterial tap in the arteries. The most commonly or easily accessible site is the radial artery. In this, after all aseptic measures, we first palpate the radial artery and then take a heparinized syringe and put the syringe vertically in the artery so that blood gushes in the syringe, and then we can send this blood in a cold ice pack to the laboratory for testing. In ICU setting, we have this machine placed in ICUs that can instantly check and give the report of the ABGs. There are certain steps in assessing the acid base disturbance of a diseased patient. First of all, you have to see the pH, whether it's normal or it's acidic or alcohol, it's acidic or basic or alkalemic. Then see the bicarbonate level. If the bicarbonate level are disturbed, then the problem is metabolic. If the PCO2 is disturbed, then the problem is respiratory. And from the pH, we can label whether it's metabolic acidosis or metabolic alkalosis, or whether it's respiratory acidosis or respiratory alkalosis. Then, fourth is the look at the compensatory response. If the pH is less than 7.4, then acidosis is the primary disorder. If the pH is more than 7.4, then alkalosis is the primary disorder. And check the compensation. If it's metabolic acidosis, then the person starts hyperventilating. If it's alkalosis, then the person starts hypoventilating. Then assess the anion gap and assess the change in serum anion gap and change in bicarbonate ions. Then assess if there is any underlying change. These are some practice ABG questions. If you get any scenario or any value in your paper, then you can easily interpret the ABG. If you have to first see whether this pH is in the normal range or abnormal range, then see the level of bicarbonate, whether the bicarbonates are disturbed. If bicarbonate is disturbed, then metabolic problem. If PCO2 is disturbed, then respiratory problem. In this case, the pH is 7.36, PaCO2 is 43, and bicarb levels are 22. So all three are within their normal range. So this is the case of a normal person. There is no acid base disturbance in this case. Here you see that pH is 7.26, means it has dropped down below 7.35. PaCO2 is 45 and it is within normal range, while bicarb is also dropped down from its normal 22 to 26 milliequivalent per liter. So in this case, the pH is decreased as well as bicarbonate is decreased, while the PaCO2 is normal, means that this is a case of metabolic acidosis and the compensation has not yet started because the PaCO2 is within its normal level. In this case, the pH is 7.52 while PaCO2 is 43 and bicarb is 31. So you can note here that pH has raised and bicarb is also increased while PaCO2 remains normal. So when pH is raised above its normal value and bicarb is also raised above its normal value, then you can easily diagnose this case as metabolic alkalosis. So there are three rules of thumb in analyzing the ABGs. If the pH and bicarb are changing in opposite direction, then respiratory disorder is present. If pH and if pH and PCO2 are changing in opposite direction, then respiratory disorder is present. If pH and bicarb are changing in same direction, then metabolic disorder is present. If PCO2 and bicarbonate are changing in the same direction, the body is compensating for an imbalance. In this case, if pH is still abnormal, the imbalance is only partially compensated. And if the pH is normal, then it is fully compensated. This is a summary of the whole topic. Whenever you have been given a arterial blood sample report, you have to first see the pH, whether this pH is less than 7.4 or whether this pH is more than 7.4, and accordingly you label acidosis or alkalosis. Then, as you know, you have two types of acidosis, respiratory and metabolic, and two types of alkalosis, respiratory and metabolic. So, whenever there is disturbance in the bicarb levels, then we label as metabolic condition. Whenever there is disturbance in the PCO2, then respiratory condition. And when there is respiratory compensation, then metabolic acidosis. Uh, in metabolic acidosis, the compensation is respiratory, while in respiratory acidosis, the compensation is renal. Similar is the case in alkalosis. When there is disturbance in the bicarb, you label it as metabolic. In case of respiratory, when the disturbance is in the PCO2, you label the case as respiratory alkalosis. In case of metabolic alkalosis, the compensation is respiratory, while in respiratory alkalosis, the compensation is renal. Thank you very much. If you have any problem, you can text me in the Google Classroom